So let's move on, and I will discuss now question 5 in this paper. It is a short answer question, May 2017. So we have here a 23-year-old male patient is referred to gastroenterology outpatient clinic with 7-week history of increased frequency of the bowel movement. So here we have history of chronic diarrhea. This is very important and relevant. We have history of chronic diarrhea, intermittent crampy abdominal pain, and associated with abdominal pain, crampy, intermittent abdominal pain. He also has a 3-week history of bleeding per rectum. So we have history of bleeding per rectum. This is important as well. So he has no past medical or surgical history of the note. He does not currently take medication. He works as an electrician, drinks alcohol socially, and smoke 10 cigarettes per day. Smoking history here could be irrelevant because a little bit later we will discuss what's the differential diagnosis. And smoking, it can it gives a clue in the differential sometimes. Examination reveals pallor, so the patient has a pallor. There is no jaundice, clubbing, or lymphadenopathy. So there is no jaundice or no clubbing and no lymphadenopathy. Cardiovascular and respiratory examination are normal. His abdomen is soft with no palpable masses or organomegaly. Recent laboratory tests from his general practitioner include the following. Here we have FBC, full blood count, hemoglobin is 11.9, so it is low hemoglobin, so the patient is anemic. MCV is 70, which is low, so the patient has microcytic anemia. White cell count 9, it's normal. Platelet 610, so it is elevated. CRP 95, so this is elevated. So from this reading of FBC, we have microcytic anemia with thrombocytosis and rise of inflammatory marker, CRP. Electrolyte sodium 144, this is normal. Potassium 3.8, this is within normal range, but in the low side. Chloride 102, this is normal. Urea 7 and creatinine 100, this is within normal range. Liver function test, bilirubin, it is 5 micromole per liter, this is normal. ALB 72, AST, ALT, and GGT, all of them liver function test seems to be within normal range. Total protein 73, this is accepted as well. This is normal. Albumin 31, so albumin is low. Albumin is low, so the patient has hypoalbuminemia. So here, very important to mention that the general practitioner sent stool culture, and stool culture is negative. This negative stool culture will rule out infectious causes in the differential diagnosis. This patient has some element of colitis. One of the important differential of the colitis is infectious colitis. So stool culture is negative, so this way we can rule out infectious cause. So here the first sub question or first question in this short answer question. List differential diagnosis for this presentation clearly indicate the most likely diagnosis in this case. So here the differential diagnosis, here we have chronic diarrhea. Chronic diarrhea, we have common causes of chronic diarrhea. We have infrequent causes of chronic diarrhea, and we have rare causes of chronic diarrhea. Common causes, it's like IBS, it's irritable bowel syndrome, or could be bile acid diarrhea, could be diet-induced, different form of malabsorption, colonic neoplasia, inflammatory bowel disease, could be celiac disease, could be drugs or medication induced, could be recurrent Clostridium difficile colitis, it could be overflow diarrhea. These are the common causes. We have infrequent causes like small bowel bacterial overgrowth, mesenteric ischemia, lymphoma, surgical causes, chronic pancreatitis, radiation enteropathy, pancreatic carcinoma, could be hyperthyroidism, could be diabetes, could be infection like giardiasis, or could be cystic fibrosis sometimes. And we have another rare causes of chronic diarrhea. So here, very important in the differential diagnosis, we have chronic diarrhea and we have a history of rectal bleeding. We have a history of rectal bleeding. So rectal bleeding. So this is very important to be mentioned because he had a bleeding by rectum. So from this differential diagnosis, IBS is unlikely. So it's wrong to put IBS in the differential diagnosis because IBS is unlikely to be presented with rectal bleeding. Bile acid diarrhea as well is unlikely to be present with rectal bleeding. The other things, rectal bleeding and abdominal pain, we have abdominal pain. And the blood test showed microstic anemia with a rise of inflammatory marker. So we have element of inflammation, and the stool culture is negative. So we can't put in the differential infectious causes. So again, the IBS is unlikely. It's wrong to put this in the differential diagnosis. Bile acid diarrhea is also it's unlikely. Diet induced here as well, it's unlikely to be diet induced. Chronic neoplasia, it's one of the differential here. One of the differential could be it is chronic neoplasia because chronic neoplasia, it can be presented colonic or colorectal neoplasia can be presented with this presentation of chronic diarrhea, rectal bleeding, and abdominal pain, and these finding in the laboratory finding. So chronic neoplasia, inflammatory bowel disease, IBD, is very important here, and he is here in this question. He's asking most likely diagnosis. Most likely diagnosis is inflammatory bowel disease. To be more accurate, ulcerative colitis is the most likely based on the history of rectal bleeding. This is very characteristic for ulcerative colitis, and the patient is a smoker. All of these consist with ulcerative colitis more. So inflammatory bowel disease, celiac disease is unlikely to be in the differential diagnosis because celiac disease usually is not presented with rectal bleeding and bloody diarrhea. Drugs, it's unlikely here because the patient, he has no drug history, so no past medical history, and he does not currently take any medication. So the drugs, it's unlikely here. So the drugs unlikely. Here, the infectious Clostridium colitis as well, it is unlikely. So overflow diarrhea as well, it's unlikely here. So these among the common, it is you have to mention chronic neoplasia, you have to mention inflammatory bowel disease, including ulcerative colitis, Crohn's, or microscopic colitis. This is the differential or the common differential. The most likely it is ulcerative colitis. Most likely it is ulcerative colitis. So the next question, identify FBC blood test abnormality and give most likely explanation. So this is the FBC, as we can see. The hemoglobin level, it is low, so the patient has anemia. MCV 70 is low, so the patient has microcytic anemia, and white cell count is normal. Platelet is high, so the patient has thrombocytosis, and CRB is high, so the patient has elevated inflammatory marker, CRB. So platelet and CRB, they represent acute phase reactant. So these acute phase reactant, they can be increased in response to various stimuli, including systematic infection, inflammatory condition, bleeding, or tumor. So this is the explanation why platelet is raised. Here, most likely we have some sort of inflammatory condition, and we have some sort of bleeding. These two things can explain why the platelet is elevated and CRP is elevated. So why we have microcystic anemia? We have some sort of chronic bleeding. Chronic bleeding can explain why we have low MCV and low hemoglobin. We have some sort of ongoing bleeding, or most likely the patient has chronic type of bleeding or chronic blood loss. This is the explanation. Here, you have to be careful in the exam. You have to mention the abnormality and you have to mention the explanation. If you will mention only the abnormality, you won't get the full mark. Here we have, you will get 2 marks. You won't get the full mark. I think for the abnormality, you will get 1 mark, and for the explanation, you will get another mark. So you have to be careful in all the questions. You have to answer all required in each question. So what further confirmatory investigation? And here you have to be careful. He is asking about confirmatory investigation. Would you arrange to investigate the patient symptoms, and what finding would you expect? The gold standard for patient with suspected inflammatory bowel disease, it is to do endoscopic evaluation, which is colonoscopy and mucosal biopsy. So this is the confirmatory investigation. And the other things here in this question, he's asking about what finding you would like to expect. So here we have 2 parts of this question. Endoscopic evaluation, we generally perform colonoscopy to obtain mucosal biopsy in patient with chronic diarrhea. The diagnosis of ulcerative colitis is based on the presence of chronic diarrhea more than 4 weeks and evidence of active inflammation in the endoscopy and chronic change in the biopsy. So you need to do endoscopy and see the inflammation in the mucosa in the colonic mucosa, and you have to do biopsy, colonic mucosal biopsy, and the biopsy will show chronic changes. So endoscopy and biopsy, it is the gold standard to confirm the diagnosis of ulcerative colitis. Endoscopic finding in patients with ulcerative colitis are non-specific. Biopsy of the colon obtained on endoscopy are necessary to establish the chronicity of the inflammation and to exclude other causes of colitis. This is very important to mention. In some cases, we have to avoid colonoscopy in some cases, but this is not the scenario here. Here is asking about what's the confirmatory investigation. So the answer, I think it is colonoscopy and mucosal biopsy. This is the confirmatory investigation. What's the finding? The finding, you will find inflammation in the mucosa of the colon and chronic changes or chronic changes in the mucosal biopsy finding. This is what's the finding. So the endoscopy, in some cases, colonoscopy should be avoided in hospitalized patients with severe colitis. If the patient has element of severe colitis, the colonoscopy will be contraindicated because of potential risk of toxic megacolon and potential risk of colonic rupture or colonic perforation during the colonoscopy. In this setting, if the colonoscopy is contraindicated, we can do what is called flexible sigmoidoscopy in this situation. The endoscopic finding in patients with ulcerative colitis include inflammation usually involve the rectum and extend proximally in a continuous manner and circumferential manner. This is very important. This can differentiate ulcerative colitis versus Crohn's disease. This is very important. So we have continuous circumferential inflammation starting from the rectum, and it is almost always involving the rectum and going proximally from the rectum to sigmoid colon, and from the rectum then to sigmoid colon, and from the sigmoid colon to the descending colon from then to splenic flexure, then to transverse colon. So it's continuous inflammation. This is can differentiate ulcerative colitis from Crohn's disease. Crohn's disease, usually they have skip lesion. You might find area involved in the colon, for example, descending colon, and then transverse colon will be free of inflammation, and then the inflammation will come back in the ileum, for example, or in the ileocecal junction. So the other finding in the ulcerative colitis, loss of vascular marking due to engorgement of the mucosa and erythematous appearance. You might find in the mucosa petechia and oxidate and edema and erosion and ulcers. Therefore, it's called ulcerative colitis. In more severe cases, may be associated with microulceration and profuse bleeding and copious exudates. Non-neoplastic pseudopolyp may be present in the area of the disease involvement due to prior inflammation. All of these are endoscopic finding in ulcerative colitis. You have to mention from them at least 2 or 3 findings. The biopsy features suggest ulcerative colitis include crypt abscess. This is the biopsy features or the biopsy finding. Crypt abscess, crypt branching, shortening and disarray, and crypt atrophy. These are the biopsy finding in ulcerative colitis. This is the classical endoscopic finding, which indicate continuous involvement of the colonic lesion in the ulcerative colitis. As we can see here, it's differential. It is diffuse, and it is circumferential, and it is continuous involvement. In contrast with the Crohn's disease, lower endoscopy in ulcerative colitis show continuous and circumferential involvement with no normal area of the mucosa. In the Crohn's disease, you might find area with inflammation, and the next area it would be normal, and after distance, you might find another area with inflammation. So this is it is crucial to mention. In patient, so the patient commences appropriate medication therapy. Good control of his lower gastrointestinal tract symptoms is achieved. He attends regularly in the gastroenterology outpatient clinic. However, he developed ongoing back pain as a result of work-related injury. He uses large quantity of oral non-steroidal anti-inflammatory drugs. This is very important and relevant to this part of the question for pain relief. The patient presents to the emergency department feeling weak and complaining of dizziness and hematemesis and anemia. So the patient presented with signs and symptoms of upper GI bleeding. Here, the patient presented with sign and symptom of upper GI bleeding. Let's differential diagnosis of this presentation. The presentation here, we have upper GI bleeding, clearly indicate the most likely diagnosis in this case. So here the causes, disorder that can cause upper GI bleeding. We have ulcerative erosive causes. We have a complication of portal hypertension. We have a vascular lesion, and we have tumors, and we have miscellaneous or other causes of upper GI bleeding. So ulcerative or erosive, this is the most common cause of upper GI bleeding. It is ulcerative and erosive causes. So in this group, we have subgroups. We have duodenal or gastric ulcer, and it's including peptic ulcer disease. We have esophagitis, and we have gastritis or gastropathy, duodenitis or duodenopathy. So it is inflammation of the stomach, or inflammation of the duodenum, or inflammation of the esophagus, and we have the ulcer, duodenal ulcer or gastric ulcer. So these the groups. From this group, the most likely cause, it is duodenal or gastric ulcer, and most likely it is related to NSAIDs. Here, the patient has NSAIDs because the risk factor for duodenal or gastric ulcer, it is NSAIDs. So most likely it is non-steroidal anti-inflammatory drugs, because the patient was in high dose and large quantity of oral non-steroidal anti-inflammatory for the pain relief, and this can cause this duodenal or gastric ulcer. So this is the most likely. So the differential, you have to mention the differential, which is could be ulcerative or erosive causes like duodenal ulcer, gastric ulcer, esophagitis, gastritis, or duodenitis, or gastropathy, or duodenopathy. A complication of portal hypertension, it's one of the differential, but here it is unlikely because we don't have anything in the history suggestive of portal hypertension. So complication of portal hypertension like esophagogastric varices, like ectopic varices, like portal hypertensive gastropathy, vascular lesion like angiodysplasia, some sort of congenital anomaly, and could be ectasia in the gastric arterial vascular ectasia. The other things could be tumor, upper GI tumor like esophageal tumor or gastric tumor or duodenal tumor, and it could be miscellaneous or others like hemophilia, like some sort of pancreatitis. So here the most likely cause, it is gastric or duodenal ulcer, and the cause of this most likely it is non-steroidal anti-inflammatory drugs. So the next question, the patient become hemodynamically unstable in the emergency department with heart rate 112. So the patient is tachycardic now, and the patient hemodynamically become unstable. The patient is unstable. The patient is hypotensive. Blood pressure is 80/45. He is resuscitated with a fluid, and decision for intubation is made. An assessment of his airway is performed. Name 5 factors which should be taken into the account during routine airway assessment. So during routine airway assessment, we have to take a history related to airway, and which is most likely it is anesthetic history, and we have to do physical examination focused on the airway assessment. So we have to take focused history related to airway assessment, and we have to do focused physical examination related to airway assessment. So, and in this history, we have multiple factors, and he's asking about these factors. And in the physical examination, we have as well multiple factors. So you have to mention the factors either related to history or factors related to physical examination. So airway assessment here, all patients undergoing general anesthesia should have complete history and anesthesia-directed physical examination. So this is important. The history is very important, and physical examination is very important. But in terms of the answer of this question, you have to mention factors in the history and factors in the physical examination. So airway history for patients who report problem with anesthesia in the past, every effort should be made to obtain and review prior anesthesia record. This is one of the factor in the history, very important. Obtain and review prior anesthesia record if the patient has any previous history of problem during the anesthesia, especially if there is any airway management problem. So in the history as well, a number of disease, either it's congenital disease or acquired disease, have been associated with difficult airway management. Like this is the list of example of the disease state associated with difficult airway management, either congenital or it's acquired. We have a list of congenital and acquired disease. In the airway history as well, a history of pulmonary problems such as asthma or COPD or recent upper respiratory tract infection or recent lower respiratory tract infection like pneumonia or bronchitis. This will impact the oxygenation and ventilation during induction. So, but so you can't mention this because You can mention that these factors or presence of the history of pulmonary problem, it can impact the oxygenation and ventilation. And this is the one of the this is one, it's part of the airway assessment. Most patients who present to emergency procedure, the patient and our patient will have emergency procedure at increased risk of aspiration during anesthesia, either because of recent oral intake or because predisposing condition. And here, the condition that increased risk of aspiration during induction anesthesia: full stomach, non-fasting patient, and emergency surgery and trauma, pregnancy after 12 to 20-week gestation, symptomatic gastroesophageal reflux, diabetic and gastroparesis, hiatal hernia, gastric outlet obstruction, esophageal pathology, bowel obstruction, increased intra-abdominal pressure like ascites or abdominal mass. And I can add to this group upper GI bleeding. Definitely, if the patient has upper GI bleeding, active upper GI bleeding, the patient and our patient have active upper GI bleeding, this patient it's at risk of at high risk of aspiration. So airway examination, though, so all of these mentioned before, this is all of these related to the history. Again, the history should be focused on the airway assessment, focused history related to airway assessment. Here we have examination, physical examination focused on the airway assessment. Airway examination, a number of bedside tests and measurement have been developed to evaluate the airway. Here in this table, it is summarized, and the airway examination component and non-reassuring finding. We have length of the upper incisor, relationship of the maxillary and mandibular incisor, relationship of the maxillary and mandibular incisor during voluntary protrusion of the mandible, and this is during normal jaw closure, inter-incisor distance, visibility of the uvula. Visibility of the uvula, we can assess this with Manambati score. Visibility of the uvula, shape of the palate, compliance of the mandibular space, thyromental distance, length of the neck, thickness of the neck, and range of the motion of the head and neck. And here we have signs or finding that indicate non-reassuring finding. And this might indicate difficult airway management or difficult intubation. So we can remember these air examination tests by a mnemonic. It's called LEMON. L, it is looked externally for characteristic known to cause difficult laryngoscopy or intubation or ventilation. E, it is evaluate 3-3-2 rules, incisor distance, 3 finger breadth, hyoid mental distance, 3 finger breadth, and thyroid mouth distance, 2 finger breadths. It is Manambati score. If the Manambati score more than or equal 3, which is score 3 or score 3 or score 4, class 3, class 4, it seems it's expected to be difficult. Or it is obstruction, conditions such as trauma or epiglottitis or peritonsillar abscess. It can predict difficult intubation or expect difficult intubation. And it is neck mobility. It is flexion and extension in the neck, or any signs of limited neck mobility, either limited flexion or limited extension. So these the 3-3-2 rule. This is the mandible, and this is the hyoid bone, and this is the thyroid cartilage, and we have the 3-3-2 rule. 3-3-2 rule. And 3-3-2 rule, it is assessed here in the evaluate 3-3-2 rule. So this is the modified Manambati score for difficult laryngoscopy and intubation. As we can see, this is a class 1. Class 1, you can see the class 1 present. You can see the soft palate, you can see the full uvula, and you can see the tonsillar pillar are visible. This is a class 2. Class 2, when the soft palate and the uvula are visible, soft palate and uvula are visible, but here the tip of the uvula, you can see the tip. You can see only the base of the uvula. The tip, it is become invisible. And the tonsillar pillars as well is invisible in the class 2. Class 3, when only the soft palate and base of the uvula is visible. Base of the uvula and the soft palate the tip of the uvula in the class 3, it is non-visible. So in terms of the difference, yeah, I think it is class 3. If the Malambas score was class 3 and more, it is predicts expected difficult intubation. And the class 4, when only the heart palate is visible. When only the heart palate is visible, so uvula is completely invisible in the class 4. Here in class 3, only the base of the uvula is visible, and the soft palate and the hard palate. In class 2, the tonsillar pillars will be absent, and the other structure will be visible. And in class 1, you will see the complete visualization of the uvula and tonsillar pillars and soft palate and hard palate. So Malambati score. So the next question, in the case where the airway is deemed to be difficult or seems to be difficult to intubate, what's the safest method to secure the airway? So here I put here the ASA difficult airway algorithm in adult. ASA, it is American Society of Anesthesiologists. They have algorithm for the adult airway. So in case of difficulty, we have to go in this algorithm to this side in the algorithm. So here we have to optimize oxygenation throughout and intubation attempt with patient awake. So this is the most important, intubation attempt with patient awake. So it is awake intubation. The safest method, it is awake intubation. If we are expecting difficult intubation, awake intubation. Here, the airway manager choice for airway strategy and technique should be based on their previous experience, available resources, including equipment, availability and competency of the help, and the context in which airway management will occur. So very important to optimize oxygenation throughout any airway intervention. During any airway intervention or intubation, you have to optimize oxygenation. So it is, you have to use low or high flow nasal cannula or high flow nasal oxygen, head elevated position throughout the procedure, non-invasive ventilation during pre-oxygenation. This is the prerequisite. So awake intubation technique, it is the safest to secure the airway in patient with suspected difficult intubation. Example of awake intubation or what's techniques we can do using awake intubation. It could be flexible bronchoscope. So you have to mention this in the answer, flexible bronchoscope. This is one option. Other option, we have video laryngoscope. This is other option. Other option, direct laryngoscope. So this is should be mentioned in the answer, direct laryngoscope. Combined technique, sometimes we are doing combined technique, for example, video laryngoscope and flexible bronchoscope, and retrograde wire-guided intubation. This is other technique, could be, this is fourth one. Other techniques, but it is, this is the most common used techniques for awake intubation. There is other technique can be used, but it's uncommon, invasive airway technique, including surgical cricothyroidotomy or needle cricothyroidotomy with pressure-regulated device, large bore cannula or cricothyroidotomy, or surgical tracheostomy. This is usually it is elective invasive airway technique. Include the above and retrograde wire-guided intubation and percutaneous tracheostomy. So this is the what's the safest method. So the safest method is awake intubation, and you have to mention the technique that you would like to use or you would like to suggest, like flexible bronchoscope or video laryngoscope or direct laryngoscope or combined technique between them or retrograde wire-guided intubation. So in this case, the airway is deemed not to be difficult. So, however, because of ongoing hematemesis, so the patient has ongoing upper GI bleeding and hematemesis, bloody vomitus, he is at significant risk of aspiration. So the patient at high risk of aspiration. Name the induction technique that should be used in this situation, induction technique that should be used in this situation. The induction technique is called rapid sequence induction and intubation. Sometimes it's called rapid sequence induction, just RSI. And in some books, you will find RSII. It is rapid sequence induction and intubation. So rapid sequence induction and intubation, this is the technique. And describe the key difference between this technique, rapid sequence induction, and standard induction of anesthesia. So rapid sequence induction and intubation, it's a virtually simultaneous administration of an induction agent and neuromuscular blocking agent to induce unconsciousness and paralysis to facilitate rapid tracheal intubation. So this is the definition. It is most commonly used for patients at high risk of aspiration. The technique is designed to maximize the likelihood of successful intubation and to minimize the risk of aspiration. This is the main goal of this technique, to minimize the risk of aspiration and to maximize the successful intubation and rapid successful intubation. This is very important, to maximize rapid successful intubation and to minimize risk of aspiration. It is essential that maximal pre-oxygenation, this is one of the rules of rapid sequence induction, we have to do maximal pre-oxygenation, and hemodynamic optimization precede drug administration during rapid sequence induction. So rules of rapid sequence induction and intubation: maximal pre-oxygenation with 100% oxygen before rapid sequence induction. And we are using predetermined doses of induction drugs given in rapid succession. Induction drugs include the inducing agent. Usually it is most common inducing agent used, it's propofol, but you can use any inducing agent. You can use other types of induction agent, but the most common one used is propofol, and inducing agent followed by muscle relaxant. The most common muscle relaxant used, it is saxamethonium. It is saxamethonium, or saxamethonium is the most common. And we have to use rapid-acting muscle relaxant. The most rapid-acting muscle relaxant, it is saxamethonium. So, and this is characteristic and unique for rapid sequence induction. And you have to mention this. Predetermined doses of induction drugs given in rapid succession, and it has to be given in rapid succession. You have to give propofol and directly saxamethonium. You won't wait until the propofol start to act. This is one of the difference between the rapid sequence induction versus the classical induction. The other thing, no bag mask ventilation, very important. No bag mask ventilation. This can differentiate rapid sequence induction from the classical induction. No bag mask ventilation, because bag mask ventilation increases the risk of aspiration. This is very important. Cricoid pressure may be applied. This is unique and characteristic for rapid sequence induction. It's called Selix maneuver. It is pressure over the cricoid cartilage to do compression on the esophagus by cricoid cartilage to decrease risk of aspiration. It can be applied. It is not a mandatory, but it can be applied because there is a lot of evidence now that cricoid pressure sometimes it can make the intubation difficult and can get the situation worse. Use of rapid onset muscle relaxant, saxamethonium, it's the best one. This is the main difference between the rapid sequence induction versus classical. And this table can summarize the comparison between routine induction or classical induction and rapid sequence induction. This is routine induction. This is rapid sequence induction. In the equipment preparation, there is no difference. Preoxygenation and denitrogenation shouldn't be a difference between them. But in the agent, when you are choosing the agent, in the rapid sequence induction, usually we have to choose the rapid-acting medication. In terms of muscle relaxants, saxamethonium is the best one. In terms of induction agent, the most common used one is propofol, but you can use any other induction agent. Induction agent, you can use in the rapid sequence, use predetermined doses of fast-acting induction agent. Muscle relaxant, saxamethonium, predetermined doses of fast-acting muscle relaxant. The most common one is saxamethonium. Ventilation, don't bag mask ventilate. This is very important. Here we do bag mask ventilation. Additional helpful maneuver, the Selix maneuver or cricoid pressure. It's called the cricoid pressure. Here in the routine induction, we don't do this. Intubation, it is intubation once the patient is paralyzed, usually within 30 to 45 seconds after giving the succinylcholine. This is very important. So this table, it summarizes the comparison between the routine classical induction and rapid sequence induction. And you have to mention at least 3 differences between the classical routine induction and rapid sequence induction. So following resuscitation, the patient developed oliguria. So after resuscitation, patient developed oliguria. Define oliguria in the term of urine output in ml per kg per hour for adult. Its urine volume less than 0.5 ml per kg per hour. This is the definition of oliguria. Let's do causal factors from the provided history that could be contributing to oliguria. This patient has already upper GI bleeding. This upper GI bleeding, it can cause hypovolemia, and this hypovolemia, it can cause prerenal azotemia or prerenal acute kidney injury and oliguria. And acute kidney injury, it can be presented or manifested as oliguria. And the other thing, the patient has he was on large doses or large amount of non-steroidal anti-inflammatory drugs. So non-steroidal anti-inflammatory drugs itself, it can cause as well prerenal acute kidney injury, and this acute kidney injury can be presented with oliguria. So in SAQs, this is one factor, and upper GI bleeding and hypovolemia. Hypovolemia is other factor or causal factor for this oliguria. And so the key thing to mention that these factors, it can cause acute kidney injury, and this acute kidney injury can be presented with oliguria. So this is the I think the last question. I would like again to hear your feedback. You can either comment in this video, and you can send me an email with your feedback. And thank you very much for following and watching this video explanation for the past paper exam. Thank you very much.